Thank you very much. Thank you, Association of Physicians of Rajkot and IMA Rajkot for inviting me on this wonderful platform for delivering the talk on lung transplantation. So, as I'm from KD Hospital in Ahmedabad, and we are doing the lung transplantation at our center, and we did almost 17 lung transplant in last 3-year span. So in this couple of minutes, we see which type of patient required lung transplantation, why lung transplantation is very important. And the stage is already set by Dr. Dhiren sir. He has wonderfully narrated the management of PE, CTF, and then ultimately the option is transplantation. So before I move, I am standing here because of these 4 institutions. I did my MBBS from CUSA Medical College, MD from Jamnagar. And then I took my fellowship from Christian Medical College and lung transplant fellowship from Leuven University from Belgium. So as we all know, transplant is not a new science. We know all these God, these Lord Ganesha. So Ganesha ne પણ જે સૂંઢ છે ને ટ્રાન્સપ્લાન્ટ કરવામાં આવી હતી. So the transplant is an old science, it's not a new science. So in this my talk, we just go through history, what all patient required, indication, contraindication, what is pre-lung transplant evaluation, what type of donors, surgery, post-op care, immunosuppression, rejection, infection, these all challenges, and then at the last our experience at our center. So the first lung transplantation was performed by Professor James Hardy. This is the doctor from the Virginia, US. He did lung transplantation for the left main bronchus tumor, and patient died with the renal failure in just 18 days. So he performed first single lung transplantation in year 1963, and then the journey begins. So there was early mortality. The second lung transplantation happened in the Belgium, where I trained in the University of Ghent in 14th November 1968, and patient died after 10 months because of the rejection. And then the story begins, and these are the first successful group of doctors from Toronto General Hospital, Canada, and they are the pioneer in the lung transplantation, and they have the highest number of lung transplantation all over the world so far. They are doing almost 200 lung transplantation surgery per year, and we are fortunate and we are proud also. The leader of this group is Dr. Saf Kesavji. He is an Indian doctor. He is a Gujarati doctor also, and he is a chief surgeon there. And they are just celebrating a 30-year of post lung transplantation, single lung transplantation. They performed their lung transplantation in 1983. So then the journey begins, and number is increasing from 1985 onwards at the world level. India is just a beginner of the lung transplantation. So what all patient required a lung transplantation? So these are the lung transplantation surgery: double lung transplant, single lung transplant, heart and lung transplantation, redo lung transplantation for the rejection of the lung transplantation surgery, multi-organ transplant for cystic fibrosis patient, liver and lung. So double lung transplant is for COPD, ILD, cystic fibrosis, non-cystic fibrosis, bronchiectasis, pulmonary hypertension, and a limited patient of lung cancer. Heart and lung transplantation is rarely required nowadays, only for a patient with a very weak left heart or Eisenmeger's or idiopathic pulmonary hypertension with low cardiac index. Otherwise, for severe pulmonary hypertension patient, also bilateral lung transplantation is the treatment of choice. So which patient to refer? So for a patient to be in a window for lung transplant, they should be sick enough to need a transplant while being well enough to undergo a transplant. So that is a terminology called lung transplant window. So we have to refer the patient very early because to prepare the patient to do the pre-lung transplant evaluation, it takes a time. And sometimes even the waiting is also longer. So we need to refer the patient early when patient is becoming sick. By the time you refer the patient, we just sort it out is modifiable and non-modifiable risk factors. So what are the absolute contraindication in whom we cannot perform a lung transplantation? So these are the main 5 or 6 contraindication: active malignancy, active infection, active kidney disease, active heart disease, acute coronary syndrome in last 30 days, brain stroke in last 30 days, acute liver disease. So these are the other organ damage, we cannot perform a lung transplant surgery. Certain infection like septic shock, active extrapulmonary infection, active tuberculosis and acute mycobacterium abscesses infection, HIV infection with detectable viral load, psychological factors, severe uncontrolled medical condition which expects is limited survival after transplant. So these are the contraindication we run in a patient when the patient refers to us. We just go through this contraindication, we do the pre-lung transplant evaluation and perform all system examination and all the reports to confirm that the patient is just suffering from a lung disease. And these are the concession all over the world. This is the guideline of International Heart and Lung Transplantation Journal, where they have given a specific indication for specific diseases. So we go through that. These are the absolute contraindication as we discuss. And this is their general statement. So whom you transplant. So when there is a pulmonologist is seeing the end-stage lung disease patient and there is a high risk of death, in 50% of high risk of death from the lung disease within 2 years if lung transplantation is not performed. Say ILD patient, you know patient is on oxygen and he is going to die in next 2 years. And another indication is there is a high chance of 5-year post-transplant survival from a general medical perspective, provided there is an adequate graft. So if the graft is adequate and there is a high chance. So if these two criteria is fit enough in any patient of end-stage lung disease, we can go ahead with the lung transplantation. Now let me begin with the disease-specific criteria. So this is the COPD criteria when to refer a COPD patient. So there are two type of criteria. One is referral and one is listing. Referral means a physician or a pulmonologist is referred to a transplant unit for the workup of the lung transplantation. And the listing means once all that contraindication is removed, pre-lung transplant evaluation is done and patient is ready to go for the transplantation, and then we list the patient in a government site so we can get a donor call. So there are two set of criteria for the COPD. One is the referral. Referral is board score 5 or 6. FEV1 is decreasing 20 to 25% predicted. Clinical deterioration for a patient who is a candidate for BLVR or a referral for lung transplantation. So this is called a referral criteria for COPD. So what is board index? So when a COPD patient is there, these four criteria you should fill enough in his OPD paper. FEV1 percentage predicted is a spirometry criteria. 6-minute walk distance, their feeling of breathlessness by MMRC score, and their body mass index. So based on these 4 points, patient is decided to have a specific board index, and then we can move forward. So what is the listing criteria? If board is increasing from 5 or 6 to 7 or 10, FEV1 is less than 20%, presence of pulmonary hypertension, history of severe exacerbation repeatedly, or chronic hypercapnia. So these are the criteria for COPD patient. What are the criteria of ILD patient? So in India, we do generally most of the transplant in ILD patient, which is a very common indication in our country, and even in other centers also. So any pulmonary fibrosis patient with following in the last 2 years, relative decline in FVC, as sir has nicely given a talk on spirometry. So spirometry is very, very important here. So relative decline in FVC by 10%, decline in DLCO by 15%, decline in 5% with clinical and radiological deterioration. So any patient of ILD with a UIP histology should have a transplant referral. Any inflammatory ILD, connective tissue disease ILD, you can refer later on. So what are the listing criteria? When there is a absolute decline despite of your adequate medical management, or patient is requiring oxygen support, or there is a desaturation while patient is on 6-minute walk distance, or frequent hospitalization because of respiratory failure, pneumothorax, or acute exacerbation of ILD, this type of patient required a listing. Then pulmonary hypertension patient. So patient already Dhiren sir has told about the CTEP patient. So any pulmonary hypertension patient on maximum medical management should require a referral based on, as in COPD there is a board index, in pulmonary hypertension there is a Rivial score. So if the score is high, you have to refer or list the patient based on the patient's functions, NT-proBNP, 6-minute walk distance, echo finding, right heart catheterization finding, PFT parameters, particularly DLCO is very, very important. So any patient required a Rivial score of more than 10, required a listing, presence of hypoxia, or a patient is particularly form of PVOD, which is very, very severe form of pulmonary hypertension, and the life expectancy is less than 2 years. Progressive and stage other organ damage or life-threatening hemoptysis. So these are the criteria for pulmonary hypertension patient. And after COVID, we saw the patient of acute respiratory distress syndrome because of COVID. There was a lot of referral for lung transplantation. So in acute care setting, when there is a ARDS, post-infectious, post-viral, patient required persistent mechanical supports. As a physician or intensivist feel that patient required a persistent support, and the recovery of these support is very difficult to vein the ECMO. And patient is having a HRCT suggestive of irreversible lung dissection. This type of patient also required a lung transplantation. General referral we do at around 2 or 4 weeks of interval of ECMO and see if the team feels that this patient is not going to be recovered from the ECMO continuation, then we should refer this patient for lung transplantation. Then what is the donor, where the donor is coming? So in lung transplantation is not like kidney and liver transplantation where the living donor is there. Lung transplantation is a cadaveric lung donor only. So there are a few criteria of ideal donor and extended donor criteria. So ideal donor is less than 55 year, brain dead, clear chest x-ray, PF ratio is more than 300, less cigarette smoking history, no chest trauma, no sputum or bowel suggestive of any infection. So this type of patient, young patient, we select as a donor. So out of 10 or 15 donor call, we generally select 2 or 3 donor because our infection rate are very high. So some infection we found in the lung and we can reject this type of lung. So there are 2 type of donor. One is brain DCD donor and DBD donor. This is the neurological and cardiological donor. So donor assessment, we accept the graft, we optimize the graft, and then we just match that donor with the recipient criteria. So these are the blood group we have to match: height, age. We should rule out the infection. We do the COVID test and routine antigen and viral antigen if everything is negative. And if the patient's criteria, recipient and donor is matching, we have at least 6 to 8 hours of time to roll the lung, and we have to, there are 2 teams working together. One team is doing the surgery on recipient, opening the lungs, and one team is assess the lung and take the lung from the donor hospitals. So what is the surgery? So there are 2-3 types of surgery. Main incision is clamshell. It's they open the chest from the front. It's not like the CABG they do the sternotomy. Sternum is preserved and they open the chest from the front. There are double lung transplantation surgery done under GA. We do at our center on VA ECMO, and we do the bronchoscopy once the transplant surgery is performed to see the anastomotic site. We take the cultures for the infection management. We load the patient for the immunosuppression. Loading dose of corticosteroid is given to prevent the primary graft dysfunction. Acute care management, we receive the patient in the ICU on mechanical ventilation or ECMO. We do the invasive monitoring. There are chest tube, empiric antibiotic, and then we start the immunosuppression. These are the immunosuppression, 3 triple immunosuppression steroid, calcineurin inhibitors in the form of tacrolimus and cyclosporine, and anti-proliferative MMF and azathioprine, which is standard in all transplantation. Then these are the complications. So there are fewer immediate complications, fewer late complications. So infections risk is very high. So we give generally a infection prophylaxis in the form of Bactrim for PCP prophylaxis, oriconazole for fungal prophylaxis, azithromycin for bacterial infection prophylaxis and rejection prevention, and valganciclovir for CMV infection prophylaxis. And we do a routine bronchoscopy to see the leak or anastomotic complication, and we do the PFT monitoring to look for the rejection. This complication is very, very important, which is called airway complication, which is around producing more morbidity in the patient. So as we all know, we transplant the lung with the pulmonary artery. Bronchial artery circulation is not transplanted because it's very tiny vessels. So the blood flow to the anastomotic site is very rare. So because of that, there is a lot of airway complications starting from sloughing of the airway, dehiscence of the airway, granulation, stenosis to anastomotic infections. So we have to take care of this patient very carefully. So one slide about the chronic rejection, and this is the study from my own teacher, Professor Verliden. So chronic rejection is defined as when the patient's spirometry is persistently low. 20% decline in FEV1 and FVC is defined as CLAD, and CLAD is around chronic lung allograft dysfunction, which is around 2 to 3 variety. BOS is bronchiolitis obliterans organizing pneumonia, and RAS is like ILD lycopatton. So patient usually has 5 years, 7 years, or 10 years, or 15 years of lifespan. They usually develop a chronic rejection. So now a few slides about our experience at KD Hospital. We performed 17 lung transplants, 16 is by mistake. 17 lung transplantation is at our center. All are bilateral lung transplant, and one patient we performed combined heart and lung transplantation with the guidance and support from KIMS Hyderabad team. Our surgical team is from there, Dr. Sandeep Patawar sir and team. From their guidance, we performed the surgery, and the rest of the team, intensive care and pulmonology team from our center. We started our program in 2023 March. 4 of our patients completed 2 years without any symptoms. First patient is about to finish 3 years in March 2026. We successfully discharged our last 3 consecutive patients in last year. So these are our patient detail. All 17 patients, their age group is lasting from youngest is 31, who has a cystic fibrosis bronchiectasis from Baroda. Most of our patient is residing from Gujarat only. Only one patient is from Rajasthan. We have 1 or 2 patients from Rajkot also, Jamnagar, Junagadh. One last 3 months back we did one pediatric patient's father. He is doing absolutely fine. So these are the group of our patient. So what are the support at the time of their transplant? You can see the first column. So we have a sickest group. We transplanted 2 patients on ECMO. Other patients are on 4 to 6 liter of oxygen support. 1 or 2 patients on HFNC. 1 or 2 patients requiring 10 to 12 liter of oxygen. And almost all the patients have successfully completed the surgical part, and few of the patients died in the ICU also. So we discussed the mortality. I'm not hiding any detail because we are just initiating the program. Our mortality is still bit high. We will just compare this mortality with world data also. So these are the patient detail. Almost out of 17 patients, we almost 9 to 10 patients are alive. The patient number 6 is not under our follow-up. She is sister of Mr. Amit Shah, our Gruh Mantri sister. So she is under follow-up of Mumbai, but she transplanted here because of she required acute exacerbation and ECMO supports. Other patients, we unfortunately 2 patients died because of, one is of severe COVID after 9 months of post-transplantation, and another patient had subarachnoid hemorrhage. 2 or 3 patients develop a sepsis and 1 develop a primary graft dysfunction. So this is our data. 10 patients are alive. So now we compare with the ISHLT 2025 registry. So the median survival for lung transplantation, everybody is asking, કે સાહેબ transplant કરાયા પછી હું કેટલું જીવીશ? So the median survival is 6.7 years. So some of the patient can live up to 3 years, 6 years, 10 years, 15 years. But where I trained, I took my training in Belgium. I have seen a patient in OPD around 10 years, 15 years, 20 years post-lung transplantation. So that gives us confidence that this can be successful in so many patients. And there is a development in the strong immunosuppression also. So which may, if you see in 2020, 30 or 2028, it may increasing day by day. In 2020, it was around 5 years, and now it is again increased by 2 years. First year survival is approximately 80%, 5 year survival is 60%, and 10 year survival is 30%. This is our patient, this is our team. So without team, we cannot do anything. So these are all our intensivists and pulmonologists. We discharge this patient from Mehsana. In earliest discharge by day 15, we discharge this patient. These are my mentors from the Belgium, whom I took my training for 3 months for lung transplantation at Leuven University, Belgium. Thank you. I'm happy to take questions if you have any questions.